Very happy to be here. The day finally arrived. We've been very much looking forward to. I'll give you a very brief update on SEGA, on subependymal giant cell astrocytoma, and I'll base this really on the TOSCA registry. So I'll start by, this is my conflict of interest statement, and the lecture is based really on the data that were presented recently at the International TSC Research Conference in Tokyo, in Japan, in September. So I'll skip this because you heard about that, and I want to start just with a just to pause very briefly on the definition of SEGA. And I think it's important to realize that historically, the definition of SEGA was based on histology. So people were operated or they died, and then under a microscope, the brain was examined and lesions were examined, and they were defined as SEGA based on a number of characteristics. And then progressively, imaging became more available, and SEGA was diagnosed based on imaging. But it really took us a very long time as a community to come to an agreement on what we then really called a SEGA. I mean, everybody knew it is about a lesion, a subependymal nodule around the foramen of Monro, which you can see there. But then if size mattered, if growth mattered, if contrast enhancement mattered, yes or no, there have been lots of discussions about it. And I think it's an important thing to keep in mind. I think the closest we came to a consensus was just during the consensus meeting when the guidelines were made in 2012. They were published specifically on SEGA in 2013. And there the community decided the SEGA is a lesion at the caudothalamic groove with a size of more than 1 centimeter in any direction. So location and size in itself, it's enough. Or a subependymal lesion at any location that has shown serial growth on consecutive imaging, regardless of size. So growth in itself can also be a criterion. And contrast enhancement is often present, but that doesn't really matter so much. So I'll probably skip this. I think I'll just want to briefly highlight the fact as well that SEGA are also they also respond to treatment with mTOR inhibitors such as everolimus. And this is based on the EXIST-1, a phase 3 trial, placebo-controlled, that looked at patients with SEGA and the evolution under treatment. And so, as you can appreciate from the images, the SEGA clearly shrink upon treatment. Now, I'll briefly give you a little bit of background on the TOSCA registry, since not all of you might be on the same page for that. So TOSCA was a large-scale non-interventional study, really designed to collect both retrospective and prospective data from both pediatric and adult patients with TSC. And so the design is really very detailed information on the core aspects of TSC, and then a number of research projects around it. And you will see many of them in our flower or petal model depicted there. And it also has a long-term safety and tolerability subgroup on a limited number of patients that are on commercial mTOR inhibitors, on everolimus. Just to give you an idea, it was really a big effort. So 170 sites in 31 countries worldwide participated, and data on over 2,000 eligible patients were collected. And so the last data collection was in August 2017. So you can see all the countries that participated there. I just want to highlight also here, when you look at the cohort, just over 60% are pediatric patients and just under 40% are adults. So it is not completely 50-50, but I think it is reasonably well balanced as a cohort. The demographic data, I think I'm not going to pause there. Males, females, there is no difference as you would expect in the disease. And I just might briefly highlight here, like less than half had genetic testing available. I think it's retrospective data, but it's also prospective data, and it really shows that many patients never had any genetic testing. But that's not what I need to talk about today. So what have we learned from TOSCA? Number of things were very interesting coming out of this study. And when we looked at the TOSCA registry, the SEGA, there was no specific definition. We collected these data retrospectively prior to the 2013 consensus. So what is reflected is really clinical practice. It is what all of us called SEGA if we had a patient and we said this patient has a SEGA according to our best clinical knowledge at the point when we were following the patient. That is what is in this registry. So it really reflects clinical practice. So according to that, and I think we can all presume these are lesions located at the foramen of Monroe, at least, SEGA were reported in 25% of patients. And this is slightly higher than what we know from literature, but I really carefully looked through the literature, what we have there. Much smaller series, and again, definition has been a problem all throughout the whole course of everything that has been written on SEGA so far. Median age at diagnosis of SEGA was 8 years, but with a considerable range. And I just briefly put on the numbers. So if we look at the 283 patients who were below age 2 years when they entered the study, so at consent, 15% had a history of SEGA, so it can really occur very early on. And just in a few patients in these below 2 years, SEGA already showed growth on some consecutive scans. So it is not frequent, but it is just to bear in mind that if you have a very small child with TSC, you shouldn't just not ignore like, he's still very young, it only occurs at later age, we don't need to worry about it. If you have to screen, check for it, and you have to be aware that it's possible that it can grow. If we look at SEGA growth, of the one that had a SEGA at baseline, these are the ones that are then being followed prospectively. Growth was occurring in just below 20%. So I think this gives us a good sense of how frequent these lesions do grow. So it is definitely not in the majority of the patients, but it's important, just under 1/5 it occurs, and it's important to keep an eye on. Do they all get symptomatic? No, they don't all get symptomatic. Under half of them get symptomatic. What to us was interesting is that the symptoms are not just like the acute symptoms of raised intracranial pressure with headaches and vomiting and other, but what we really saw as frequent symptoms were an increase in seizure frequency, behavioral disturbance, or regression or loss of cognitive skills. And then if we look at the group divided for the ones that we had information on for the mutational status, SEGA were more frequent, and they occurred at a younger age in patients with mutations in TSC2 compared to the group of patients with mutations in TSC1. So it doesn't mean if you have a TSC1 mutation, you're safe with respect to SEGA, but if you have a TSC2 mutation, you might really think like, you need to be even more vigilant maybe. So it's younger and more frequent. And then treatment modalities in the registry included surgery and mTOR inhibitors. I put the numbers there. This clearly shifted as the prospective evaluation went on, because we started the TOSCA registry when mTOR inhibitors just were being studied for the indication of SEGA. And so this really practice clearly changed with the follow-up of the registry, with more people using mTOR inhibitors. And then just for the rest of the time, I want to focus a little bit more on the adults, because I think this is really something that has not been studied so well before. We really don't know much about it. If we look of the 220 adult patients who had a history of SEGA, it still continued in the study in 186 patients. So it means the other ones had a treatment or were operated for SEGA, and so for prospective follow-up, we have 180. No, I'm doing there. Among this group, growth since the previous scan was reported again. We come to a similar number than in the overall cohort, around 21%. Very frequently, the SEGA were multiple and bilateral, so in more than a third of the cases. And I just want to point out here, if we talk about growth, the median time between consecutive scans for the whole cohort, but so also for the adults, was 1 year. So it's a yearly follow-up, and then looking at, is there a change, yes or no? And so then growth was there in around 20%. And then we also were interested in the adults, like, can it still happen? Can SEGA newly occur? And so during the follow-up period, which was up to 5 years, SEGA, newly diagnosed SEGA were reported in 14 adult patients. Now, we did not collect images all the time because that was not part of the registry, so we cannot compare and verify, but this is really what is reported from the clinicians that participated in the registry. And here you see the division by age. So 2 in the 18 to 25-year-old, 8 were diagnosed between 25 and 40 years, and then 4 after the age of 40 years were newly diagnosed with the SEGA in the prospective part. My time's already up, 1 minute. Good. Symptoms, not so much new, very similar. So also seizures, behavioral, and headaches for the symptoms in the adult group. Treatment, very similar also. That's not really new. And then if we looked at a mutational status again, what I want to highlight here is that all the patients who experienced a newly diagnosed SEGA, so this is the figure I just showed you in adult age, all of these had a mutation in the TSC2 gene. So if at adult age something newly occurs, it's a small group and we don't have a lot of patients, but they all had a mutation in TSC2 gene. And also growth since the last scan, it is more frequent in the one with the TSC2 mutation. And also when we looked at SEGA-related symptoms, more frequently associated with the TSC2 compared to the TSC1 mutation. So I'll fly to my conclusions. So I think what we learned, or what was definitely interesting for us, was that if we look in this big cohort, and it's definitely the biggest series of patients with SEGA that we have been able to study so far, we see that it might be a bit more frequent than was previously reported. Symptoms are definitely not only related to acute symptoms of raised intracranial pressure, can be much more subtle. And so it's important that when things change, when behavior change, when there is something about the seizures that you don't understand, like, this is unusual, or where there is a loss of skill or a regression, then to keep in mind, like, maybe something is changing. And I think also for the adults, we're not recommending a change in practice according to screening, because the current guidelines say screen up till age 25. And I don't think we need to keep screening everybody. It doesn't make sense. But I think it's very important just to be aware of it and not think like, okay, this person is an adult person. SEGA is never going to be a problem anymore. No, if it's an adult person and things are changing, you should still think like, but are we really sure that the SEGA is really not growing, or does this person has a SEGA? So it is just a matter of being aware and not just be blinded to the fact like, adult patient SEGA is not a problem. So both new occurrence, it's rare, and SEGA growth, also rare, but it's possible. So it's important to remain vigilant, and then again, even more so in the ones with the TSC2 mutation, but I'm very careful because I just don't want you to think like, if it's TSC1, then again, I should ignore it. No, you just have to bear it in mind, but be more vigilant in the ones with the TSC2 mutation. And that's what I wanted to tell you. I wanted to thank especially the TOSCA team. It has been a great adventure to collaborate with so many clinicians and so many colleagues and friends from all over the world. It really has been very, very nice. And I also want to thank the people in my team, the people in the Leuven team, be-TSC, Petrus and Lauren, people from the Koning Boudewijn Stichting, and my Epistop family. Thank you.